تسلم. السلام عليكم. ربنا يحتكم العافية. Being in medicine during this COVID era and in Syria is a hard thing to do so. ربنا يكتبها في ميزان حسناتكم إن شاء الله. As Yasser was saying, this is about bone marrow transplant and it's just the basic. So if you have any question at any point, just ask. So we'll make it interactive more than a lecture if you want to. Again, my name is Ali Solomon. I work here at St. Jude in the Department of Bone Marrow Transplant and Cellular Therapy. And my presentation today is just the basics of transplant. So the outline of it, I'll touch on the types of transplant that we do. I will touch on HLA typing 101, roadmap for transplant, toxicity, positive supportive, basic supportive care and outcomes. So what is transplant or what is hematopoietic stem cell transplantation? It is the process of replacing the bone marrow stem cells with new hematopoietic stem cells. It's broad and it encompasses a lot of things. That's what we are going to discuss in the next couple of minutes. So just back to histories. The history of transplant goes to the 1950s, where the first trial of transplant was given 18 cc's of bone marrow transplanted to the patient with aplastic anemia. This happened in the 39. The patient didn't survive, as you may imagine, because there was no HLA typing or matching or anything like that. Then on the 50s itself, there is a lot of research, and we discovered the graft versus host disease. We described the HLA in the 50s. And then bone marrow transplant was done in dogs, mainly in Russia at that time, using high dose of radiation. The first successful transplant happened between twin to twin. That's what we call synergistic transplantation, and this happened in 1959. In the 60s, the clinical trial started to happen. And in the 60s, the first successful transplant done for non-cancer indication happened in Sloan in New York for a SCID baby. And then the discovery of cyclophosphamide as an alternative for radiation, that was huge. 70s, we described graft versus host disease. We get the first match unrelated donor transplant in the 70s. We discovered cyclosporine, and we have the first registry started in the 70s. In the 80s, it's booming. We discovered the busulfan. We described the combined effect of graft versus host, graft versus leukemia. Registration of the National Bone Marrow Transplantation Donor Registry, or CIBMTR, happened in the 80s, and then so on. But I think that it all started with this man, Donald Thomas. He died in 2012. He got in 1990 the Nobel Prize for Physiology in Medicine, together with Joseph Maury. Both of them, they gave the Nobel Prize for discovery of organ and cell transplantation in treatment of human disease. He's a pioneer. He did the first SCID transplant in New York. And then he took some time off because that was not successful. And then he went back to Seattle, Washington, and started doing it again. He is the history of transplant. Another way to think about it also for time for cellular therapy, this is just a linear transplant or linear timeline saying what I said, but here we added some cellular therapy. So DLI, or donor lymphocyte infusion, was discovered in the 1988. The first CMV T cell infusion happened in 92. EBV T cell infusion happened in 94. And then the CAR T therapy, or the cellular, the engineering of the T cell. So the first CAR therapy happened in 93, and Eliana trial for CD19 CAR T happened in 2003. And then in 2017, the CD19 CAR T approval happened here in the FDA. So what is the annual number here in the US? These numbers are adjusted. So we have in blue line, the autologous transplant, and I will go through definition in the next couple of slides. And the green line is allogeneic transplantation. And if you look closely here in the 90s, there is a huge bump of transplant in the 90s, but that get declined. And the main get reduced. And the main reason for this time here, a lot of physicians thought that autologous bone marrow transplant is going to cure breast cancer. So they start doing it for breast cancer. Unfortunately, that's not true. And that's why it dropped down. So if you look at both of them, allogeneic and autologous, they go line by line. So they go together till the 60s. This is here as the source of the bone marrow. And again, I will talk about this later. So we have cord blood, that is the CB, unrelated donor. URD is unrelated donor. The CB is cord blood. URD is unrelated donor, peripheral blood marrow or bone marrow. And these are the numbers. So the majority of it is, if you look, the cord blood started early in the 2000 and it's up and down. But the numbers for the unrelated bone marrow and peripheral.
عفوا عليك، بس الكورد بلود يعني يقصد فيه يعني أخذ العينة من الحبل السري.
Yep. So getting the stem, getting the stem cell source. You can get the stem cell source from cord blood. That's usually after delivery of the baby. And again, I'll expand on this in one of my next slides. What's the difference between the cord blood and the peripheral blood and the bone marrow, and why you choose what you choose. So yes, the cord blood is after delivering a baby, there is a stem cells in the placenta. So you take it, you save it, and you leave it there. The good thing about it, it's baby, it can engraft really good without giving graft versus host disease. But the problem with it, it is limited dose. So you get what you get, the number of cells you get from that cord blood. Peripheral blood is obtaining the stem cell from peripheral blood. So just from a vein, just like a blood donation. Bone marrow is going to the source, and it's a procedure. Again, I think by the end of the discussion, that will make more sense because I have 1 or 2 slides between the difference of them. Here, I'm just giving the numbers. So allogeneic transplant, again, these are where you get it from, whether it's bone marrow or peripheral, whether it's from a brother or sister or other relative or unrelated donor. So you can see the number are going up through the years, and this is mainly because we improve in how we do transplant. Overview of the stem cell transplant. So every stem cell transplant, it have the ability to either go to a common myeloid progenitor cell or a common lymphoid progenitor cell. If you concentrate in the lymphoid part, it's either the natural killer or the small lymphocyte. Small lymphocyte will give you the B cells and the T cells. The B cell can proliferate to be plasma cells. This arm here mainly fight infection and mainly knows the self from non-self, meaning that it knows your tissues. The common myeloid, it gives you the megakaryocyte, which will give you the platelets, give you the erythrocytes, it give you the mast cells, and it give you the myeloblast. The myeloblast will divide into basophil, neutrophil, eosinophil, and monocyte that goes to macrophages. So what we are transplanting is this stem cell, the big one that give all the other cells. So here is the definition of or nomenclature. When I say autologous transplant, I mean the recipient own cells. When I say allogeneic transplant, this is donor stem cells. So you can get it either from a related donor, meaning that brother or sister, father or mother, or alternative donors. The alternative donor is unrelated bone marrow donor, a person that you don't know that match you in the registry, or from umbilical cord blood. This is usually anonymous because you donate it after the delivery of the baby from the placenta, and it goes to a freezer somewhere. And then peripheral blood. The synergistic is identical twin transplant. We don't do that much of synergistic because for the most part, whatever caused the twin to have a disease, most likely his identical twin will have it. But again, there is other instances that we can do synergistic transplant or twin-to-twin transplant, identical twin transplant. Other nomenclature, so allogeneic transplant is either related or unrelated. So if you concentrate as related, it's either match or mismatch or haploidentical. So if it is a match related, so we call it MRD, non-sibling, if it is not brother, or MSD, sibling, if it is brother. Mismatch, we call it MMRD, so mismatch related donor transplant, or haploidentical, which is father or mother, or aunt or uncle, anybody who shares one haplo allele in the HLA. Unrelated, it's either match or mismatch, so MUD or MMUD. This lingo or this way of saying it, it just puts everybody in the same page when we talk about transplant overall.
عفوا علي ممكن بس السلايد الماتشد يعني معلش تشرح انه الماتش شو يعني شو يقصد فيه هو المتطابق بالصيغه النسيجيه الماتش يعني المتطابق.
Yep, I have a slide on that when I come to the HLA matching and how we do it.
تمام.
So if you hold that thought just for a little, I will come to it.
تمام.
All right. So the basic process for autologous transplant. So this is a transplant from your own stem cells. Mainly we do this because the chemotherapy or the whatever we give this patient is going to kill the bone marrow. So this bone marrow is not going to regenerate again. So the way to do it is you collect the stem cells and preserve it and put it in the fridge. Then you prepare the patient and you give him the chemo. And after you finish the chemo, you reinfuse this stem cell back. It will regrow and it will create the red blood cells, the platelets, and the immune cells. So this is your own cells. And again, I will talk about why we do this and what disease is going to come to this. So why do we do autologous transplant? We do it mainly because the toxicity to the hematopoietic system is those limiting effect for that treatment with chemotherapy. Sometimes you call it stem cells are used to rescue this patient after high dose chemotherapy. So autologous transplant, think about it as high dose chemotherapy with a stem cell rescue. What is the indication for pediatric to do autologous transplant? So it's usually used for diseases that are not primarily bone marrow disease. So solid tumor, mainly neuroblastoma, brain tumors, lymphoma that is relapsed, or other solid tumor like immunosarcoma, retinoblastoma, or Williams tumor. So these are not a bone marrow disease. This is our other disease, but to cure them, you are going to give high dose chemotherapy. That high dose chemotherapy, it will kill the bone marrow and it will never regenerate. So to avoid that, you collect it before you give them this chemotherapy, you put it in the freezer, you give them the chemotherapy to cure their neuroblastoma. And after you finish the chemotherapy, you infuse that cells back. We also do it for gene therapy. So what is the difference between solid organ transplant and bone marrow transplant? Solid organ transplant like kidney transplant, heart transplant, lung transplant, and so on. So in the solid organ transplant, you give a few immune cells. There is no conditioning or preparative regimen for solid organ transplant. It's just surgery. The major clinical problem is rejection. You reject the kidney, you reject the lung, you reject the liver. Immune suppression, you get it lifelong. In the bone marrow transplant, you are basically giving a new immune cell. So you're giving all the immune cells. So it's giving many immune cells. You need to prepare the patient with immune ablation. And I will talk about what is the conditioning and what we use. The major problem is what we call graft versus host disease. So this new immune cells that we transplanted, it recognizes all the organs in the human body as this is not me. So if I got bone marrow transplant from my brother or from an unrelated donor, that bone marrow will recognize my brother, but it might not recognize me. And if it doesn't recognize my skin, it will try to kill it. It will not, if it recognize my gut, it will try to kill it. If it recognize my liver, it will try to kill it. That's what we call graft versus host disease. Immune suppression is less, it's months, and mainly because we are going to train this immune system to recognize me by immune suppression and then take it off. I hope this is clear and not confusing. Please speak up if it's this confusing. So the sources for the last 10 years, it's always been, again, I'm going to talk about cord blood and donor blood and how we do it. It's just a different slide than what I said earlier. So match a related donor for less than 18 years. We use bone marrow more than peripheral blood. The source of the stem cell, where we go to get the stem cells, is bone marrow. The estimated graft source throughout the years. You don't need to know this or memorize this, but just know that it's increasing, and the haploidentical transplant is increasing more and more. What we use for graft versus host prophylaxis for haplo transplant, mainly what we call BOSI. Again, I'm going to talk about this conditioning in the next slide. So here is the basic process for allogenic transplant. That was autologous transplant. This is allogenic transplant. So we have a patient who had a disease in his bone marrow we want to cure. We will get the donor, we will get the stem cells out, and we'll freeze it. The way to get this stem cell is either from peripheral blood or from the bone marrow. And then we prepare the patient by giving him conditioning chemo and radiation. And after that, we infuse the cell to the new donor, and we will wait for engraftment. So here is the source and the pros and cons for each cell dose. This is what Yasser was asking about earlier. So we can get the stem cells from the bone marrow, or we can get it from peripheral blood, or we can get it from umbilical cord, so UCP. The availability, the bone marrow is limited because it's a surgery. You take the donor to the OR, he's gone under sedation or anesthesia, and you do about 50 injection in the bone marrow in each side to collect these stem cells. It takes anywhere between 45 minutes to 2 hours to collect these stem cells. For peripheral blood, it's just like blood donation. You get hooked into a machine. The machine will take the blood out, will circulate it, will collect the stem cells, and we give it back. The downside of peripheral blood, you have to mobilize it from the factory, from the bone marrow to the peripheral blood. And you do that by using growth factor, the GCSF. So you give the donor GCSF for 5 days before collection to make his bone marrow make a lot of stem cells, and then he push them out to the peripheral blood. So it's also limited because of that. The cord blood is ready, it's stored, it is typed, it's sitting somewhere. And if you have a match, you just get it. For the donor, again, the surgery is higher risk, but peripheral blood is not that much. Collection for bone marrow, it's hard. Again, it's surgery. For peripheral, it's moderate, just like blood donation. Umbilical cord is easy. It's sitting in the freezer somewhere. Bone marrow, usually we collect it once, sometimes twice, but for the most part, we do it once. For peripheral blood, you might need to collect multiple days. So you can collect today. If you don't get the cell dose you want, the patient or the donor will come the next day to get another collection. Collection risk for bone marrow is higher risk because it's a surgery. For peripheral blood is moderate. Cost for bone marrow is high. Cost for peripheral is high. Cost for cord is very low. Stem cell content usually for the bone marrow is adequate because you are getting it from the source. For peripheral, it's adequate because even if you don't get it in the first day, you can get it in the second day. But the main thing is the T cell content. And I will talk about why that is important. So in the bone marrow, the T cell content is very low. In the peripheral blood, the T cell content is high. In the cord blood is low because they are immature. HLA matching, more restrictive, less restrictive in cord blood. And I'll talk about that in a minute. Engraftment time. Usually, peripheral blood engraft faster, meaning that usually when you give peripheral blood, engraftment happen around 10 days after transplant. For bone marrow is later, but the slowest one is the cord. And why is that? Because of the T cells. T cells help engraftment. So if you have higher T cell, you get faster engraftment. If you have lower T cell, you get lower engraftment or longer engraftment. But the other side is the T cell also cause graft versus host disease. So the lowest the T cell, the lower risk of graft versus host disease. So that working higher engraftment put you in a higher risk of developing infection because you don't have neutrophil for longer time. Lower engraftment, meaning that you engraft sooner, so you are in lower risk of developing infection, but at the same time, you are higher in developing acute graft-versus-host disease and chronic graft-versus-host disease. So with that in mind, you choose your poison very wisely, you choose your graft very wisely. Why do we do allogeneic transplant? So we do it to eradicate unwanted cells, so like leukemia clone, or to replace a single defective cell line, so sickle cell disease, thalassemia, or to replace immune system for aplastic anemia. Aplastic anemia is immune disease, it's hyperimmune disease, it's autoimmune disease. So that's another reason. Or to provide a source for cell that makes enzyme, and I will talk about some of these diseases in the next couple of slides. But the main thing we do it for leukemia is for the effect of graft versus leukemia effect, meaning that the new graft is gonna kill the leukemia, not the chemo itself. So here is the indication for transplant. So to eradicate malignancies, we do allos. It's mainly done for CML if now they failed tyrosine kinase inhibitors. We do it for AML in CR1, in complete remission 1 if they are high risk, or in CR2 if they have a relapse. If they come with a relapse disease and you put them in CR2, then you take them to transplant. In acute lymphocytic leukemia, we do it for Philadelphia positive. We do it for CR2 relapse, mainly here in the US. We do it for early relapse. Late relapse, you can treat them with chemo only. And then GMML, juvenile myelomyelitic leukemia. To deliver a high-dose chemo, we do autologous transplant. It's mainly for lymphoma, in relapse, Hodgkin and non-Hodgkin, solid tumor, neuroblastoma, lymphoma, and Ewing's, as I said. To replace a single cell line, think about it, red blood cells, sickle cell, thalassemia. You can transplant this patient and they will have normal life after. You do it for platelets disease, so they like megakaryocytic thrombocytopenia. You do it for neutrophil disease like CGD, chronic granulomatous disease. For lymphocyte like SCID to Scoldrich, or combined variable immune deficiency, CVID. To replace hematopoiesis, so for example, aplastic anemia, MDS, or bone malofarier like Fanconi. We also do it to replace enzyme, as I said in my last slide. So those are the storage disease. So Kraber, Gusher, Hurler syndrome. You can do transplant to replace these or to provide cells that has normal enzymes. Some other indication for it, like osteoporosis, some people does it for HIV, autoimmune diseases, or gene therapy. Again, I'm not going to talk about the rare cases that people does transplant for, but the previous one, these are the most common indication for transplant. But if you look throughout the last year, the main thing that we did transplant here in the US for is ALL or AML. So leukemia is the majority of our transplant. For other cancer, there is we do autologous more than allogeneic, but autologous, the main one is ALL or AML in kids. So this is the roadmap for transplant. As soon as we have an indication, we know this patient needs a transplant, we'll go through this. So the first thing is HLA. This is what Yas was talking about earlier. So the HLA is the major histocompatibility protein. This identifies the class 1 and class 2. It's through T-cell receptor, TCR, or the CD8 or CD4 for T helper. Usually it recognizes, each one of them recognize one class. So the CD8 recognize class 1 and the CD4 recognize class 2. Remember, major histocompatibility equal HLA. So why is this important? If you look here, if you have a donor T cell and a donor other cell, they know each other and they live happy. The recipient also, they know each other and they live happy. So if you transplant them, then you give a donor T cell to a recipient other cell. So one of two things can happen. If the donor T cell recognize the recipient other cell, so skin, gut, liver, as not cell, it will start to destroy it. So that gives you the graft versus host disease. If the other thing happen, the recipient cells recognize the T cells are not me and start to kill it, then that will give you graft failure or graft rejection. That's why it says here, say you, I don't want to be you. So this is the two major things, either graft failure or GVHD. We now know how to prevent graft failure. We know it very well, and it's not existent in transplant. Still, you will see it very rarely in transplant, where a patient will reject the graft, but not as common as GVHD or graft versus host disease. So what it means to have HLA matching? HLA matching, or the major histocompatibility from physiology, it's in chromosome 6. It is A, B, C, and DB, TQ, and DR. The A, B, and C, they are the major histocompatibility class 1. The major histocompatibility class 2 is what we call DB, TQ, and DR. So we want this patient to be at least matching in 6. So if you are matching in A, B, and DR, and this is mainly in the 90s and when transplant started, then we call it 6 out of 6 match. We don't use that anymore because we have high resolution matching now. So we use all of them. So we use A, B, C, DB, DQ, and DR. And in that case, these are 12 out of 12 match. So when I say match SIP, most likely it's matched 12 out of 12 in these locuses in chromosome 6. When I say a match unrelated donor, most likely are 12 out of 12 matching. When we say mismatch, meaning there is a mismatch on this locus, we usually want them at least to be matched on these 6. So if a patient had C that is mismatched, that's fine. If a patient had DQ or DB mismatch, that's fine. But at least they have to be matched in A, B, and DR. These are the most important ones. So that's why when Yasser was asking in my previous slide, and let me just go back to it to remind everybody what we're talking about, this mismatch. So match is match 12 out of 12. It's either a non-sibling or a sibling. Mismatch is mismatch on one of these locus. It's mainly C, DB, and DQ. And then the rest is this here. Is that clear, Yasser and Ahmed? And does that make sense? I'll take that as yes. So this is 12 out of 12 match. So why the source matter, or where we get it matter? Because of the degree of, or the risk of graft versus host rejection increase with the degree of mismatch. So the best one is your identical twin. Then the next is the matched sibling. The matched sibling will be more matched than the unrelated. Unrelated is after, and then the mismatch related or unrelated, and the last is the haplo. When you go down this list, you have increased risk of graft versus host disease and increased risk of rejection. The next step is to do the pre-transplant testing for recipient and donor, for the patient and donor. It is a bunch of blood work to determine the infectious disease risk. We do eye exam, we do ear exam, dental, we do a pulmonary function test, we do echo and EKG, we do GFR and creatinine clearance, we monitor the liver, and we do disease evaluation, meaning that if they have leukemia, where they are in CR or not, and what is their MRD, minimal residual disease. And after that, we do the conditioning. So conditioning chemo is a recipe. It's a combination that's given before the stem cell infusion. It is usually a combination of radiation and chemo. And the purpose of the conditioning is to immune suppress the recipient or the patient to prevent rejection, to myeloablation or make a space for the graft, and to eliminate abnormal or malignant cells. So this is the 3 goals that you want to accomplish by giving conditioning chemotherapy or preparative chemotherapy or preparative regimen, whether it's radiation or chemo and radiation together. So immune suppression for the patient to prevent rejection, myeloablation to make a space for the new graft to grow, and to eliminate abnormal or malignant cells. So from that, we have 2 types of conditioning, what we call myeloablative. So this is more cytotoxic, and non-myeloablative. This is more immunosuppressive, and we call it also reduced intensity or RIC. So if you look throughout the last 10 years, myeloablative transplant that was used, it's mainly busulfan, cyclophosphamide based, plus other things we add. The theme here is your busulfan and TPI are the myeloablative part. Your cyclophosphamide, the Cy, and the flu is your immune suppressive part, and then other. For the reduced intensity, again, it's also busulfan and TPI based. The only difference is between myeloablative and reduced intensity is the dose. For busulfan, if you give more than 9 milligram per kilogram is myeloablative. If you give less, then it is reduced intensity. For TPI, if you give more than 8 grays, whether it's fractionated or not, it is myeloablative. If you give less, it is reduced intensity. So these are the two types we do. Then we come to the stem cell infusion. Stem cell infusion, or what we call day zero, it is just a regular blood transfusion. It is the cells are collected and given. So for the patient, that's it. Just giving me a blood transfusion. And for the other healthcare, the nurses or the doctors, what do I do now? And what you do is depend on what does the product look like. If it's a fresh product, meaning that you collected the same day you are infusing it, it is just normal blood transfusion. So you look for normal transfusion reaction. If it is cryopreserved, meaning that it is coming for a match, a related donor from other city or other state or other country, or it is preserved in any way, then this product has DMSO. DMSO is the chemical that we use to preserve the stem cells. And this DMSO can cause facial flushing when it's infused, can cause tinkling sensation in the back of the throat, just like throat scratch. And it has very strong smell and taste. For me, it smells like garlic. So when you walk in the patient room, you just smell like garlic everywhere. But also there is a rare side effect from it. It can cause bradycardia, it can cause abdominal pain, it can cause encephalopathy or renal failure. So this is the thing to watch for when you give the product. And then what happened after that is the waiting game. So this is the timeline. Transplant usually it is dated. So when you give conditioning, we call it day minus. So day minus 10 or minus 9. When you give the stem cell, it's day 0. And from there, it goes day plus 1, day plus 30, day plus 100. So for the first part, you have mucositis. Mucositis is a side effect from chemo or conditioning you give. There is a risk of something called sinusoidal obstructive syndrome. So it's a liver disease. And I'll talk about this a little bit. You have a risk of breast or posterior reversible encephalopathy. You have your acute GVHD and chronic GVHD. And then you have your infection risk all the time. This is here what will happen at each time point. So around day 30, they will start to engraft. The mucositis will taper down, but then your risk of VOD or sinusoidal obstructive syndrome is more. You will engraft white blood cells, then the T cell function will start to survive, and then the first survival endpoint is 1 year, and the second survival endpoint is 2 years after transplant. And in this time, you taper your immune suppression. So for autologous transplant, it's the same. It's mainly cell infusion. We also time it by day 0, day minus, day plus. And then you wait for engraftment, and then you give their vaccination. So the waiting game after transplant. For hospitalization, patient stays in hospital till they are having engraftment. And what is engraftment is ANC, absolute neutrophil count, more than 500 for 3 consecutive days. Usually happens between day 14 to day 35. Patient gets out of the hospital. There is transplant restriction after that. This restriction is 6 months to 1 year. No school, no public crowded indoor space, malls, movies, churches, mosque, only outdoor socialization. Immune recovery, neutrophil engraft first, platelets second, and then RBCs. So usually neutrophil depend on where you get the source, as I talked about. It's engrafted around 2 weeks, platelets second, and RBCs third. T cell reconstitution takes up to 1 year. What kills the patient, usually it's infection, bacteria. This is initial first 180 days. fungus initial period, and then viruses all year. So a word about SOS, or sinusoidal obstructive syndrome. It's a liver disease. It's a microthrombus that happen in the hepatic venules. It usually happen between day 8 and day 40. And the symptoms and sign of it is weight gain, right upper quadrant pain, high belly, thrombocytopenia, mainly from forming these thrombuses, ascites, mainly from VOD and hepatic vein hypertension or hepatic circulation hypertension, and hepatorenal syndrome, so renal insufficiency. Management is supportive. Here in the US, there is a non-FDA approved agent, which is defibrotide. In Europe, it is approved for use of treatment of SOS. Just the United States takes more time to approve this agent. Fever management, if there is a fever, the first thing is thorough exam, look for the perineal skin, line site. We do non-invasive testing. We don't do rectal exam or anything like that. You culture all the line. If the ANC is less than 500, then your treatment is either cefovim, ceftaz, or zosine. You add vancomycin if there is mucositis, or the patient looks sick. We consider adding antifungal if the fever persists despite antibiotics. And then if the culture is positive, you treat accordingly. Patient usually stays in antibiotics until they are not neutropenic. Here at St. Jude, we do it differently, but this is the general rule. A patient who after transplant, if he had fever, they stay on antibiotics till they engraft. Again, this is what the main bacteria that cause disease. So for the first pre-engraftment phase, it's mainly gram-negative plus gram-positive and GI species. After they engraft, it's mainly gram-positive and encapsulated bacteria thereafter. For the viruses, it's all the virus, basically. Anything, HSV, CMV, varicella, HSV6, EBV. For fungal, it's mostly Aspergillus or Candida species. Pneumocystis, if you are not in pneumocystis prophylaxis, which is Bactrim or Cetera. Blood pressure, we monitor the blood pressure repeatedly. We treat it if it's high. We repeat it after 15 minutes. We use fast-acting nifedipine or hydralazine. And the main reason why we treat high hypertension, because if the platelets are low and you have high blood pressure, your risk of stroke or breast is high. So you transfuse platelets and you treat hypertension very aggressively. If the blood pressure is low, we give NS bolus, and then we think about etiology, why they are having low blood pressure. It's mostly infection, chemo, or hydration status. If they needed a new oxygen requirement, so examine the patient, get the venous blood gas, chest X-ray, think about etiology. Mucositis usually may cause like obstruction of the airway, volume overload and capillary leak, infection, transit lungs disease, or diffuse, what we call diffuse alveolar hemorrhage. It is a side effect from transplant. I'm not gonna touch on it, but it is very rare, but it happens. It's called diffuse alveolar hemorrhage, happen after transplant. Volume management, we weigh the patient. Usually it's PID, the more the better. Sometimes we do TID 3 times a day, and we trend it. We monitor the I and O's very strictly. We monitor the urine output, cc per kg, electrolytes daily. We think about intravascular versus extravascular fluids, but mainly the main thing we do is we weigh them so often. Breast or posterior reversal encephalopathy typically is the setting of hypertension 80% of the time. Symptoms are headache, vision change, seizures or convulsion, altered mental status. Mainly it's from chemotherapy, but also from calcineurin or cyclophosphamide, which we give to prevent graft-versus disease. It can happen outside bone marrow transplant setting. It happens with cytotherapy, cisplatin, or gemcitabine too. Management, stop the seizure, aggressive blood pressure management and control, and transfuse platelets. Give magnesium, because for the most part, magnesium would be low in this patient. The general limitation for allogeneic transplant, it's transplant-related mortality. Still, this is very lethal therapy, 5 to 10 I will say 10% of people might die during transplant. Then you have your donor availability. There is 25% chance of having a sibling match, and this is bare sibling. Only 30 to 40% of people will have 10 out of 10 match in the registry. And this is for, it's so less for non-European background. So us as Middle Eastern or African-American, they have less chance of getting a match because most of the people in the registry, they are Caucasian. And then adult volunteer donor must be willing and healthy. Graft rejection, it's not common that much now. We know how to prevent it from happening, but graft versus host disease is the common lethal things. So this is pictures of what graft versus host disease of the skin looks like. It's a skin rash, and usually it doesn't spare the sole of the foot or the palms of the hand. What is treatment for graft versus host disease or acute treatment, acute graft versus host disease? The first line is steroids, and it's high doses of steroids. It's 2 mg per kg of methylbrate. You treat for 1 to 2 weeks, and after that, you taper the steroids. After 1 week, if the symptoms did not resolve, we call that steroid refractory. But the second line is multiple. There is no clear winner for the second line. So that's why I'm not going to talk about it. But the first thing is steroids. So this is overall outcome for transplant throughout the years for ALL and AML using match-related donor and match-unrelated donor. It's been steadily increasing through the years. So this is year by year. In the between 2000 and 2005, the survival rate is dismal. It's like 60%, but now we are up to 85%, and it depends on your disease status. This is the outcome by type of transplant. So for autologous, the main reason people die in the first 100 days is from their primary disease. The second is infection. The third is organ failure. Match-unrelated donor, all the same, if for Hablo or for non-Hablo. But you look here, after 100 days, the main killer is the disease itself. So we're still not good in treating relapse after transplant. Prognosis overall, as I said, it depends on the disease, donor, and previous existing toxicity. If you look at sibling match transplant, for example, aplastic anemia, the survival rate is more than 85%. For multiple relapse AML is less than 20%. For most diseases, 50 to 60%. But one thing to remember, 100% of them will die without transplant. And that is the end of my presentation. And I'm happy to answer any question.